natural valve, it will grow as well as the child is growing. 16, 17 years when they grow, it grows. So majority of the patients, it will last even 20 years, 30 years, 40 years. One of the celebrities who had is Arnold Schwarzenegger. Because we know how Arnold was, how active he was, and how fit he was, and that was very important for him. He cannot take blood thinners. So he had a ROS procedure, and it's done well. In the patient, particular patient, he was very young. Procedure is 58, but initial procedure it was more than 25 years ago, almost 26 years ago. Cherian sir and Madhushankar sir did the ROS procedure. So they replaced the aortic valve with the pulmonary and put a pulmonary valve homograft, which lasted 26 years. I doubt even mechanical valve would have supported that much. Any bioprosthetic valve put 10 years fail. Now what has happened is both of them failed. This aortic autograft, it's significantly failed and it was leaking significantly. Pulmonary valve narrowed and leaking. Because the outflow valve blood and outflow valve and inflow valve, mitral valve, tricuspid, severely started leaking. So moderate to severe mitral regurgitation, severe tricuspid regurgitation. Right side pressure normal 30 but in the patient 90 blood pressure 100, right side pressure 90 to 100. So much severe pulmonary hypertension. They'll sit, they'll struggle, abdomen was distended, peripheral edema. So literally he was struggling. There was no possibility of sleeping, no breathing possibility. It gradually got worse. For 1 year it got worse to the stage he was not able to stay at home. He was in the hospital most of the time. So he has visited all the major hospitals in the city, and all of them said redo surgery is not possible, because as soon as we go on the pump to replace the valve, he will not come out of the pump. With a pulmonary pressure of 100, replacing aortic valve, pulmonary valve, we don't know what is the situation with the mitral and tricuspid, he will not survive. Transcatheter procedure, transcatheter procedure normal aortic valve aortic valve disease calcium the valve the calcium will hold the valve. But natural valve degenerate there was zero calcium. This was a completely non-calcified valve. Adula dedicated valve whatever valve available, Gina valve that is not available in India. It's available only in US, Europe. So we have to use the best available valve, that is the Edwards valve, in that position. We needed a lot of assessment, a lot of imaging. Dr. Ashik is here, we have got a fantastic imaging specialist. One of the problems is, if we keep, this is the actual valve, Edwards valve, the calcium it can go to the LV or go to the aorta, migrate aorta. So we needed a support team. Dr. Arun Kumar was there on standby. If something happens, surgery pandrathuku. We had the perfusion team on standby. Dr. Madhushankar was also in theatre. So we had 2 surgeons on standby, perfusion team, whole team. This is not a procedure you can do in any hospital. You need a cath lab, which is also an operating room. It's called a hybrid operating room. So procedure problem, we cannot shift the patient to theatre. Immediately we have to go on the bypass machine. Immediately we have to do surgery. So thank you, Arun. And he cancelled all his surgeries. Normally Arun Kumar sir does 2 or 3 surgeries. He cancelled all his surgeries. He stayed in the cath lab throughout until the procedure is done. He left the cath lab. Thank you. So normally sir will be operating on that day in Radial Road, Kauvery. So the whole team was there on standby. So the reason I am explaining this is not something that can be done by one person like me or any other hospital. It will not be possible. So you need a hybrid operating room. You need a surgical team, you need a perfusion team, the entire team, and you need a good imaging team as well. More than that, you need the hospital support. The reason is, this is not a very low cost procedure. 2 valves and surgery, we are talking about almost 50 lakhs. Most patients will say, the first time of trouble, if the patient doesn't do well, or if the patient doesn't survive, that's when you get into trouble. Then all the problems will come about the payment, about the issues, all the other things. From that aspect, Dr. Mahesh, Dr. Ayyappan and Dr. Arvind, they all said, whatever it is, we'll support, we'll take care. So without that kind of support, we cannot do this kind of procedures which has got a very high mortality. So thank you, Mahesh. And I think without your support, all these patients we have done, it will be impossible. I think the hospital support is very, very important. And more than that, we have a very experienced Cath lab team. Ainar and Sarah, they are there. So it's almost like they know what I want exactly. So this is the issue with that. So with regard to coming back to the procedure, what was done was, he was seen and nobody wanted to operate. And nobody was taking the chance to do the transcatheter because the dedicated valve was not available. So we said we'll do it. We explained clearly to the patient, and I used a lot of AI as well, apart from my international colleagues, because in the case it's not done so far in the world. So there is nothing to fall back to go and see the literature to see what can be done. There are isolated cases where they have replaced the autograft in the valve, the isolated cases of pulmonary valve. But this kind of double valve is not done. So we have discussed with all the international colleagues. But apart from that, there was a lot of AI I used. The clot platform, there is a DOSI simulation platform, there's a FISOP to simulate each valve, Edwards valve, Merrill valve, self-expanding valve in each position to see what gives the best result. So it was almost 1 week of sleepless kind of simulation, and then I was showing to Kamal, this is what it is. If we put this pulmonary metronic valve போட்டாக்க எப்படி இருக்கும், Edwards valve போட்டா எப்படி இருக்கும், aorticல அதே போல ஒரு valve போட்டு. Lastly, we confirmed that we will put an Edwards valve in the aortic position and a metronic valve in the pulmonary position and dilate, because the pulmonary was narrowed so much, dilate slowly and then put the valve, because there were a lot of issues. Pulmonary valve rupture aglam, aortic valve migrate on. I'll show you in the slides, a couple of slides about what was done. But it's not about the procedure, it's not about the sort of world's first, that is not about it. These things are possible to do when you have a good team. The most important thing is that as soon as the patient came to OPD, he came and fell in my feet. I said, no, you are 58 and 54, don't do this, the whole family, don't do this. He said, for the first time, as a human being, you just want to eat and sleep. That's the most important requirement. Otherwise, there is no point in living. So, nalla thoonga mudiyadhu sir, nalla saapida mudiyadhu. I'll show the slides and then I'll ask Madhushankar sir after that to talk a couple of minutes about the RAS procedure in India, because the maximum number of RAS was done by Dr. Cherian and Dr. Madhushankar, more than 250 cases. Internationally, there is not much experience. So the most experienced RAS experience is from India, from Cherian team. I think Cherian sir himself presented in Europe and US. I think sir will talk about.
முன்னால் ஹோமோகிராஃப்ட் கிடைக்காம இருந்தது. இப்போ ஹார்ட் டிரான்ஸ்பிளான்ட் கூடின பிறகு ஹோமோகிராஃப்ட் கொஞ்சம் ஃப்ரீயாக கிடைக்குது. ஏன்னா அந்த இறந்தவங்க டொனேட் பண்ணவங்க அந்த இறந்து புதுசாக வைக்கக்கூடிய ஹார்ட்டு, பழைய ஹார்ட்டு, இதில் கிடைக்கக்கூடிய அயோட்டிக் வால்வ், பல்மனரி வால்வ் எடுத்து வச்சுக்கலாம் இப்போ அதிகமாக. ஆனால் இது இல்லாத காலத்தில் அரௌண்ட் 2000 along with Dr. K.M. Cherian, we did about 250 RAS procedures. And this is one of the most successful series. ஏன்னா youngest patient வந்து 3 months old. And a senior most person, 76-year-old, he wanted a RAS procedure. So we had a very good success rate. And now after 20 years, majority of them are coming back because of the failure of either of the valves. In fact, sir didn't know, there was a patient before this who, what we have done is Dr. Raghuram did the aortic valve alone, because at the time pulmonary valve was nalla irundhathu, and recently we did the pulmonary valve by percutaneous valve. So one surgery replacement, another one percutaneous valve. Anyhow, RAS is no more, but RAS procedure is one of the fantastic, innovative procedures for aortic valve disease. Thanks for this opportunity to explain.
சொன்ன மாதிரி இது வேர்ல்டு ஃபர்ஸ்ட் கேஸ். இதனோட பிளானிங் வந்து அவ்வளோ ஒன்றும் ஈஸி இல்லை. ஒரு 1 வீக்காக சார் இதை பற்றி டிஸ்கஸ் பண்ணிட்டு இருந்தார். ஏன்னா அந்த ராஸ் ப்ரொசீஜர் பண்ணதுக்கப்புறம் 2வது தடவை நாங்கள் சர்ஜரி பண்ணுறதுன்றது அவ்வளோ சாதாரணமான விஷயம் இல்லை. எல்லாமே உள்ளே வந்து அது அடிஷன்ஸ் சொல்லும். அந்த இருதயத்தோட எல்லா ஸ்ட்ரக்சர்ஸுமே அதோட ஒட்டிகிட்டு இருக்கும். அது 2வது முறை சர்ஜரி பண்ணுறதுன்னு ஒரு சாதாரண விஷயம். அதில் இறப்பு விகிதம் ரொம்ப அதிகம். இது வந்து அந்த 2 வால்விலுமே உள்ள டிரான்ஸ்கத்தீட்டர் வால்வ் வைக்கிறதுன்றது அதுக்கான முன்னாடியே பண்ணுற அந்த ஏஐயில் சிமுலேஷனில் பண்ணது, அதுக்கான டிஸ்கஷன் பண்ணது, அதுக்கான பேக்கப் பண்ணது. சார் ஆல்மோஸ்ட் 2 வீக்ஸ் இதுக்காக ப்ரிப்பேர் பண்ணார். இது வந்து ஒரு ஃபென்டாஸ்டிக் ஃபஸ்ட்டு ரிப்போர்ட்டட் கேஸ். நம்ம எல்லாருமே அது பெருமைப்படுற விஷயம். காவேரி குழுமத்தில் எங்களுடைய வாழ்த்துக்கள் சாருக்கு.